Stress urinary incontinence. Urinary incontinence is the involuntary passing of urine. The prevalence of urinary incontinence ranges from 9.9% to 36.1% and is twice as high in older women as in older men. There are 4 types of urinary incontinence. Stress incontinence refers to urine leakage associated with increased abdominal pressure from laughing, sneezing, coughing, climbing stairs, or other physical stressors on the abdominal cavity and, thus, the bladder. Urge incontinence is involuntary leakage accompanied by or immediately preceded by urgency. Mixed incontinence is a combination of stress and urge incontinence, marked by involuntary leakage associated with urgency and also with exertion, effort, sneezing, or coughing. Functional incontinence is the inability to hold urine due to reasons other than urologic and lower urinary tract dysfunction. Overall, 30% of women will develop stress urinary incontinence within 5 years after their first vaginal delivery. Stress urinary incontinence is associated with significant social and financial costs. History taking aims to assess the problem and its duration, rule out any secondary illness, any medications that might be the culprit. The parity of the woman and history of any pelvic surgery. The physical examination aims to assess vaginal prolapse and turgor for any neurological condition, and objective demonstration of stress incontinence on cough stress test. The urodynamic studies may help to confirm incontinence, assess urethral function, and evaluate compliance. Other tests include urinalysis, post-voidal residual urine test, and cystoscopy. The management of stress incontinence includes non-surgical interventions, pharmacological therapy and surgical interventions. The non-surgical interventions include behavioral modification, pelvic floor exercises with or without biofeedback, and other accessory teaching aids. A behavioral modification program aims to help regain bladder control by increasing the effective capacity of the bladder, thereby reducing the symptoms of urinary incontinence. It includes patient education regarding the function of the lower urinary tract, fluid and dietary management, timed voiding, prompted voiding, or bladder training, and avoiding log or diary, and pelvic floor exercises or Kegel exercises. The pelvic floor muscle training helped the patient strengthen the muscles of the pelvic floor. These exercises consist of repeated, high-intensity, pelvic muscle contractions of fast and slow twitch muscle fibers. Pelvic floor electrical stimulation is the external application of electrical current to the pelvic floor. Low-level electrical currents might stimulate reinnervation of the pelvic floor or modulate a change in muscle fibers from a ratio of slow to fast twitch muscle fibers. The vaginal cone is a tampon-like device that is inserted into the vagina and kept in place by active muscle contraction of the pelvic floor. These commercially available and widely used products come in a variety of weights. The patient is instructed to insert progressively heavier cones as she becomes adept at maintaining the lighter ones in the vaginal canal. Occlusive devices can be extraurethral or intraurethral. The pharmacologic therapy includes alpha-adrenergic agonists, tricyclic antidepressants, selective serotonin and norepinephrine reuptake inhibitor antidepressant, hormonal therapy and periurethral injectable agents. The surgical options include anterior repair, transabdominal suspension, laparoscopic procedures, transvaginal needle suspension procedures, and sling procedures.